We're going to talk specifically this morning about low testosterone. And in the process of doing that, we're going to cover some other very important topics as it relates to prostate cancer. Can everybody hear me?
No, sir. No. They're working on the volume right now.
All right, well, I'll try to speak up then, okay? We're going to cover a pretty broad topic this morning. So a little bit of background. Steve kind of alluded to some of my background. I'm originally from St. Martinville. I did go to USL, it's UOL now, but USL when I was there. And I did spend time in Nashville getting my urology training. And once again, I have a very special interest mainly on the cancer side of things. Robotic, minimally invasive urologic surgery is what I enjoy. So this is going to be how the morning's going to flow. We're going to give an overview about low testosterone. We're going to define it. We're going to talk about the benefits and monitoring. Talk about some very unique situations that I see in my practice. Talk about how testosterone relates to prostate cancer. And also talk about other associations that we can oftentimes correlate low testosterone with. And at that point, we'll kind of close everything out and open it up to you guys. So once again, a little disclaimer, I'm a urologist. I'm not an endocrinologist, meaning I have a broad knowledge of all things male. But as far as hormones, normally endocrinologists are a little bit better. I have a special interest in it. I am a prostate cancer surgeon by trade. And in that fact, I have to be able to be very facile with understanding testosterone. I have no conflicts to disclose. So these are common issues that walk through my door. Men who are having trouble peeing or men who are concerned about, sorry about that. There we go. About their prostate. Also, kidney stones can be a very common issue that people come through the door with. Erectile dysfunction and low testosterone. Now, it's interesting that we may be able to make an argument that some of these are directly correlated with this, or at least related to it. So a little, how some of these guys feel coming.
I'm sorry, can the lights go off in front because the contrast is very bad to see.
We're working on it.
Talking to the mic.
All right, it's reverberating up here a little bit. Are you guys hearing me fine?
Not when you turn your head.
Okay. Let me see if I can get it here. So you guys probably see watching a football game or throughout the weekend, there's advertisements everywhere you look, on the web, on TV. Do you have low T? Is your sex drive low? I had low T. They're everywhere. So let's define testosterone. If we look strictly from a definition standpoint, it's basically a hormone that maintains male characteristics, and in one word, manliness, okay? So if we break that down a little bit further, we look specifically at some of the things we may be aware of as far as muscle strength and size, bone density. We refer to that as kind of the anabolic effects of testosterone. Now, there's also other roles of testosterone as it relates to controlling your hair, skin, and also prostate functions and sperm production. And that's referred to as the androgenic side of things. So this is kind of a busy slide, but I'm going to try to condense it down. This is describing how things normally work in the body, whereby basically the hypothalamus stimulates the pituitary to make two precursor hormones called FSH and LH. These have very important roles in guiding both sperm production and testosterone production. Now this system is on a loop, so basically there's a feedback mechanism where it's very tightly regulated. We'll come back to that in a moment. So what does this go by? You hear low T, you hear hypogonadism, andropause, male menopause. We're all talking about the same thing, but you may see it referred to by many different names. So these charts are basically representing what your testosterone level does in a man as you age. So age is represented here on the x-axis and testosterone is on the y. So basically, when you're younger, your levels are at their highest. And as time goes forward into the 70-year-old man, those levels will diminish. And that's what we see as a normal part of aging, okay? Now, I want you to pay attention to the range in the 40 to 50-year-old guys, anywhere from 500 to 800. And that roughly holds true right in here, okay? So how do we define it? How do we know what's low? That can be somewhat controversial depending on who you ask. Depending on the lab that it's drawn by, they'll list a different reference value. Most of them list anywhere from 280 to 300 as their low end. I'm going to present some literature that suggests we can even consider levels as low as 350 with associated symptoms that we'll talk about as low. So basically, there's a sliding scale depending on what the patient presents with and basically who you ask. So this is, the AUA is the American Urologic Association. It's the governing body that oversees all urologists. They put this out as a primer for us, basically looking at a couple of very, very large studies on aging men. And they define their, you can look at what they define their criteria as, and it's kind of all over the map. But, those guidelines that I gave you in the ballpark of the low 300s with symptoms is kind of what most urologists and practitioners abide by. So what are the symptoms of low testosterone? A lot of guys that come through my door, the issue relates to erectile dysfunction or not being able to get or maintain erections. There also can be diminished sex drive, energy being sluggish, noting at work that they just can't get through the day, and their wife is telling them they're just a different person, just feeling very moody, almost like a postmenopausal woman. So how do we make the diagnosis? So based off of these symptoms and a focused physical exam by either your urologist or your primary care doc, and some follow-up blood work to help screen for it. So if the diagnosis is confirmed, we have a couple of options as far as replacement therapy. Now, creams can be administered, patches can be administered, injections can either be administered through a physician's office or the patient can be trained to either inject or have their spouse self-inject them. There are even implants that can be implanted under the skin that can last for a longer duration of time. Pill forms have really fallen out of use due to past toxicity. Whenever it's processed by mouth, it has to go through the liver. These approaches avoid that, okay? Now, it's a little busy slide, and I'm sorry if I'm going to try to define what this is. It's basically comparing all the approaches, injections up top, pellets next. Now, I'll tell you, we don't use these. These are buccal administration, meaning dissolving in the mouth. We don't use a whole bunch of that here. At least I personally do not. Patches, and then the creams or the gels. So basically what it breaks down to is, if we look at the first issue, which tends to be the big one, is cost. Your creams and your patches tend to be a little bit more on the pricey side. Now, the injections tend to be more reasonably priced. Now, pros and cons. When I talk to patients about it, I've found in my experience, younger patients tend to be more drawn to the injectable forms. Whereas my younger patients, 50 years or less. More functional patients. Now, in the older patients, meaning the 65 plus crowd, where if we're talking that their energy's a little off, I've found that they favor the cream and they want to avoid the injections. Now, there's no absolutes in the situation and we individualize it. But basically, the first question becomes, can you tolerate a needle or not? And then from there, we make decisions. Because some men will say, yeah, I don't mind injecting myself. I've personally found that I think men get a little bit higher, more predictable levels with injections as opposed to creams. There's a lot of variables as it relates to how big the patient is, how well it's penetrating, and two, compliance, meaning you got to use it every day. And no offense, but I don't trust my men to use things every day. The injections work around that in the sense that they can be administered either in 2 to 4 week intervals, and they stick around long, and you just got to remember to do it once a month. Now, in someone who I'm really worried about, we will sometimes talk about pellets, where the pellets can last anywhere from 3 to 6 months. So that gives you ensured compliance, but just in my practice, I just haven't. In the rare instance, I think my partner has done a couple for guys who just cannot or will not inject or don't tolerate the cream, but I think that has more limited use in my office. Now, what I have found is people who are using the creams, especially the busy person who's traveling, it becomes inconvenient to travel with the actual dispenser, which is almost like a big bottle of Lubriderm or skin lotion. So what they'll use oftentimes, they'll have patches for when they travel, and they'll use this at their home base of operation. Now, what we find is you do have to exert some caution so as not to come into contact with anyone after you've applied it. The manufacturer states within about 30 minutes the cream has dried, but we always caution people who have females in the house or young children that they have to keep it under control.
How long activity do you get from the implant?
3 to 6 months.
Okay.
3 to 6 months. Once again, I probably have the least experience with the implants, but 3 to 6 months is what is quoted. So once again, there's lots of different ways to skin the cat, so to speak, but it often comes down to a discussion with what's going to work best for the patient and their lifestyle and what works for them. So our goal of treatment, you remember we talked about that 500 to 800 range when we looked at that downward slope? That's kind of what I try to achieve in men who are on replacement therapy, and also improving their clinical symptoms, okay? Even if we undercut this a little bit, oftentimes men will see improvement, whether it be in their sex drive or erections or energy. Oftentimes we do see improvement. So the benefits, obviously, in normalizing all the things that we talked about. Men will sometimes see improvement in body composition. So this testosterone is the same hormone that took you from a boy to a man, and it is the same thing that we talk about athletes abusing. Now, I'll come back to this sentiment that we're taking a deficient person and repleting them, but men will find that it's easier for them to work out, and indirectly that helps them reduce the fat that they're carrying, and you can carry more muscle mass, relatively speaking. And in that same vein, improvement in diabetes and the metabolic syndrome. This is a conundrum that afflicts our society as it relates to diet. It's normally obesity, specifically truncal or around the belly obesity, high blood pressure, and cardiac issues, and insulin insensitivity or resistance, if you will. Increase in bone density. As the muscles get stronger, the bone and the underlying structures also will. That has long-term implications in the aging man as it relates to fall risk, fractures. So it keeps a lot of people out of trouble in that regard. Now this is a little bit of or maybe an overgeneralization, but the trend is what I want you guys to know. And we talked about the relative deficient guy who has all the things we talked about, truncal obesity, probably has pretty poor bone density, and he's kind of what I call, not to be insensitive, skinny fat, meaning thin limbs and just kind of carrying a lot of truncal obesity. So side effects that we have to watch for on the testosterone replacement. We know that men will have acne specifically on their back as it relates to the androgenic effect, meaning the skin growth, the skin effect that testosterone will have. Men will also note that they will see diminishment in size of the testicles. I'll kind of explain why that happens in a couple of slides. We also worry about sleep apnea, male pattern baldness, or receding hairline, gynecomastia, which would be pretty rare with the doses that we are using, but will occasionally occur in a gentleman, which is breast swelling and tenderness. Urinary issues or difficulty emptying the bladder. Now this gland right here, I'll have a bigger slide in a moment. That's your prostate. It sits right below your bladder, and it's kind of the gatekeeper of urine as it makes its way out. So anything, whether it be a benign enlargement as you get older, will provide almost a roadblock, if you will, to urine flow. We worry sometimes that through the androgenic effect of what testosterone is doing, that we can make the prostate grow artificially and precipitate some trouble peeing, okay? Prostate cancer. Now, I have a dozen or so slides devoted to this, so we'll come back to that, okay? But that's always something that in a man who is on testosterone, we will probably be a little bit more vigilant about monitoring for this. So we talked, you remember this busy slide we showed earlier. So now I'm going to show you what happens when someone is on testosterone, whether it be injection, whether it be cream, whether it be implant. We are kind of circumventing the natural order of things by introducing it into the system. So what happens, your brain's pretty darn smart. It's going to detect that you have mega doses in your system, so it's going to tell all the master commands, just shut down production. You don't need to work anymore. So what happens is all the downstream guys that normally are there, they get shut off too. Well, guess what happens? Sperm production is going to get shut off, and your own natural production is going to get shut off. So what that leaves you with is diminished sperm production. So we'll talk about how that has implication in younger men where fertility is still a concern. It's going to blunt your own production of testosterone naturally that you may have. And like I said, the fertility issues, and as a product of this, of the input not being there to produce sperm, that's why the testicles will diminish in size. They're not having to work as hard. And basically this normal, what we call the HPA, hypothalamic pituitary axis, gets disrupted, okay? So back to monitoring. When a man is on testosterone, they need to see, the administering physician for physical exams, prostate checks, and laboratory analysis every 6 months. Sometimes we can space them out to 12 in people who've been on it chronically. We normally settle on 6, though, in most of my patients. And once again, prostate exam, Hematocrit. Hematocrit is a measure of your oxygen carrying capacity. It's red blood cells. So basically, we know that when testosterone is administered, part of the reason you feel better is because this will artificially elevate. In rare instances, it can get exceptionally high, and at that point, we have to talk about options of either putting a patient on an aspirin or even having them give blood to diminish that volume. If it gets to too high of a level, we worry about the viscosity or the thickness of the blood, if you will, causing clots. That does not happen, that does not happen quite often, but when it does, it's easily addressed. PSA is the other thing as it relates to prostate cancer monitoring. We'll come back to this in a moment. So I want to talk about a couple of clinical scenarios that come through the door, okay? Things that I see and that I just want to make mention to bring to light. So we'll talk about the young man, the man who is on anabolic steroids through a street pharmacist, if you will, the man who's on chronic narcotics or other drugs, and basically men who have low testosterone who have been treated for prostate cancer in the past. So let's start with the young man. And by young man, I'm probably referring now to the 40-year or younger kind of guy. So basically, we want to make sure that nothing strange is going on with this guy. This is not the typical 60-year-old guy coming in with complaints. It's pretty rare if I have a 20, 30-year-old guy come in. Red flags are going off in my mind to look for other things. And that's a little bit above the scope of what we're going to talk about. But the big issue is preserving his fertility, because we can fix him with testosterone, but as we showed with that other chart, we may render him infertile if we do it. So the other issue is sometimes these guys require a formal opinion from either an andrologist or an endocrinologist just because of the level of complexity they present. So back to this busy chart again. So unlike the past one I showed you, we're actually tinkering with the system higher up at the level of the hypothalamus. So we're given a medication that will either indirectly or directly stimulate it to produce the downstream guys that we want, thereby fertility and his own endogenous or natural production of testosterone remains. So once again, that's what we're trying to do, and it preserves this axis and it doesn't disrupt it. Now let's talk about the chronic steroid user. These guys can be very complex, and quite frankly, they can be a mess to sort out. And sometimes they come in they're socially addicted to these things. They're almost dependent on them. So once again, this is the same slide I put up. They're having all the problems that we worry about long-standing, because some of these guys have been on this for years, if not decades. And then, they get to a point where they are having problems where they either can't get them, or they're just having a lot of irregular problems that they can no longer keep up with. So once again, all the things we'd worry about, these guys are experiencing. Now these guys are a little bit more complex to deal with, and oftentimes, I tell you, I've erred on getting formal endocrinology opinions on them, because like I said, most of them are at that point dependent. Chronic narcotic user, I think it's underappreciated in our society how many people who are either on, Lortabs or the chronic pain medication for their back, because that just always gives them trouble. I've had a couple of guys come through the door, and it takes about 10 seconds to figure out what's going on. But basically, there's a well-established relationship between chronic pain medication use and low testosterone. There's even documented evidence of the hypothalamus being disrupted by use of ecstasy, which is MDMA. Antidepressants also are suggested to cause some of the same effects through this. Now notice I put men with controlled prostate cancer. We're going to make a distinction between a man with active prostate cancer and a man who's either been treated definitively and is in what we'll call remission versus the man who is actively having a problem. So we're talking here specifically men who've been treated definitively. So this was an article in the Journal of Urology in 2013. So basically it was looking at ethical considerations for administering testosterone to men who've been treated. So here's the conclusion that they reached. Basically, there's no controlled studies that have been performed that demonstrate safety in men with prostate cancer. But there are studies out there that do suggest that such treatment will not pose a risk for recurrence or progression. Now, once again, there's no definitive recommendations that are available. But studies there are out there that suggest that there are men that have been treated afterwards and do fine. I can tell you from personal experience within my group, I see patients who've been on it for a decade with my retired partners who I maintain, and they've done fine. Now, we'll talk about how we select those guys and how we make that determination. Now, I'll tell you, most of the formal guidelines that are out there, whether it be from the Endocrine Society and these bigger organizations, I think most of them will sit on the fence as far as making a formal recommendations, and most advise against administering testosterone in prostate cancer. And I think a lot of this is more medical legally motivated than anything else. So let's talk a little bit about prostate cancer. So once again, there's this historical association. We're going to talk a little bit about how this came to be. And we're also going to address kind of how common a cancer it is in men. So looking at, these are 2013 American Cancer Society statistics. I just want to call your attention to prostate being the most common cancer here. But if you look, number 4 is bladder cancer, and number 5 is kidney and renal pelvis cancer. So a lot of people ask me in my family, and why'd you be a urologist? And I often circle back to this. Well, some of the more common issues that afflict men, we get to help fix. So once again, this is just further demonstrating the probability of developing cancer, and once again, prostate headed up that list.
Just 1 second.
Sure.
Kurt Chastain, are you in here?
That's okay. So let's talk about this history of how testosterone came to be intermingled with prostate cancer. So this is Charles Huggins. He did a lot of important work back in the 40s. Basically, they looked at men who had really advanced prostate cancer, and they actually castrated surgically these patients, meaning removed the testicles. By default, that removes the influence of testosterone from the system. And they noted that, hey, these patients got a little bit better and they responded. So there was an association that, hey, maybe prostate cancer is somewhat driven by testosterone. So these were followed up by other studies in the 60s and 80s that basically took a little different stance on things. They said, well, let's see in someone who has cancer, prostate cancer, and what happens when they're administered testosterone. And once again, they saw that in these very small studies that they had cancer progression, okay? But once again, these were guys that had a pretty advanced disease. So early on, there was this belief that became dogma that basically testosterone causes cancer to progress. And so within the medical community, there was a consensus that, testosterone administration, we should never give it in prostate cancer. Let's just be safe. So once again, this circles back to this paper that I already quoted that, despite that, I think there's a substantial amount of evidence that has been accumulated since that time to suggest that there is safety and that we maybe need to draw a little bit different conclusions. So I think the conclusions that I've come after reviewing the literature is this. Men who have an active problem with prostate cancer, we should not be giving you testosterone. Now, the rigorous screening that we talked about is a way we help guard against that. Now, testosterone in and of itself does not cause prostate cancer. There's been an upswing in men who are receiving testosterone over the last couple of years, and we have not seen this rapid, large spike of people coming through our doors with prostate cancer. So there's a lot of good data out there that backs this up. So if you guys have been looking over the last year about prostate cancer screening or PSA screening, you probably know it's a pretty controversial topic, okay? So back in May of 2012, the U.S. Preventative Services Task Force. Now, this is the group that sets the timelines and the recommendations for colon cancer, breast cancer, all the screening that goes on in the country. So they basically gave prostate cancer screening a level D recommendation. I mean, that's not very good. And they actually recommended to stop screening for prostate cancer. Now, I can tell you, the governing body, the American Urologic Association, was very upset with that recommendation, as we felt it was doing a disservice to people to suggest that the test should be completely abandoned. There was agreement that we should maybe rethink the way men are screened, and I'll address in a second how the AUA has recommended we change. So the current guidelines that were set out in May of 2013 show that our current recommendations is that a man under the age of 40 should not be screened for prostate cancer. Now, the old recommendation was that starting after the age of 40, we would start screening men once a year with a digital rectal exam and a PSA. Now, that interval has been moved back to 55, okay? They recommend between 55 and 69 that either once a year or every other year that the men receive a PSA and or a prostate exam. they make a recommendation that beyond the age of 70, we should probably stop checking men for prostate cancer. Or, now here's the kicker, and here's the thing that makes it easy for them to say in a boardroom somewhere, but not be in the office with me, or a 10 to 15 year life expectancy. I tell you, not all 70-year-olds are created equal, because I have guys that come through that look great, and I have 55-year-old patients that look miserable. So it's very individualized, and I tell all my patients when we have a discussion about this that we're going to take it day to day, and we're going to kind of look at and see what's going on with them. And oftentimes, it's a decision that the patient and I make. You know, the guidelines are just that, they're guidelines. But I've had a couple of guys who've been screened in the past, and they're in their late 70s, and they want to keep getting screened. And I told them that we will continue to do that. We'll just be very conservative with the information that we get. So let's just summarize what I said. They really want us to focus on the 55 to 69-year-old gentleman. Now, I will say that in men who have a significant family history, meaning a father, a brother, or a grandfather with prostate cancer, I still move this down to 40. And I still think that the recommendations hold that in a high-risk patient, 40 is still the appropriate age. And I've learned that through, I've had a couple of patients that I've seen in my own practice that came in with very, very bad prostate cancer, and their dad had it, their grandfather had it, their brothers had it. So it was pretty predictable, and they presented in their early 40s. And once again, you know, stopping screening, that's a point of contention. I will tell you, most of my guys, when we get to 80, we're talking about definitely stopping. I tend to try to be conservative with these guys. But the overall theme is we should probably be doing less, and that may be doing a service to our patients and not a disservice. I'll explain that in a second.
Is that the government? You think it's the U.S. preventative program? Does the federal government tell us to do this?
You know, the government does have a say in that, but there are other organizations that have also recommended that we should probably be more conservative with PSA screening. So let's talk a little bit about how, you know, if a PSA elevation or a problem is noted, how do we investigate it? And herein lies some of the problem, is the way we diagnose this, and this sounds all fancy, but basically an ultrasound probe is placed into the patient's bottom, into the rectum, and 12 pieces of the prostate are biopsied. There's some discomfort associated with that, and there's a risk of bleeding and infection from that procedure. It's a small one, but when it happens, it's no fun for all parties involved. And I only remember the people that have the problems. I don't remember the countless ones that do fine. We don't have good technology that's less invasive to make this diagnosis. MRI is starting to play a larger role, and in some centers, it mainly used in the man where a PSA abnormality has been detected, but we cannot find a cancer. At bigger centers, they are fusing MRI and biopsy together, but most run-of-the-mill patients coming through the door, that's not something we would do straight away. It's for the patient who we feel that there's a problem, but we're having trouble detecting by a regular biopsy. So, prostate cancer treatment options. There's been a big initiative to really try to get people to embrace active surveillance. Now, traditionally, the tried and true methods were either radiation options or surgical options. These other options, we're not going to spend a lot of time on. I still consider them, for the most part, experimental. They haven't stood the test of time, but they are available as treatment options. So here's kind of a head-to-head comparison, and I'm sorry, maybe I shouldn't have picked red. It's projecting a little poorly, but I'll try to make it make sense. So active surveillance is the most conservative approach. And basically what it involves is just watching the cancer. If there are certain parameters present on the cancer and the patient is a certain age, sometimes we try to outlast the cancer and not do anything about it and let them pass away with the cancer and not from the cancer. Now, once again, the concern would be disease progression and our patient anxiety. I tell you, I've had this discussion with people and they're like, "Doc, I know what you're saying, but I'm going to go home and I'm going to worry about this every night." So once again, it's ideal for older patients who are wanting to avoid the things we're going to talk about. Not ideal for the 45 or 50-year-old patient who we diagnose, because obviously their longevity will supersede any advantage of watching it. So external beam radiation and brachytherapy. These are both flavors of radiation, if you will. Now, external beam, no surgery at all. You go to a radiation oncologist and you get a series of treatments that are administered. Now, once again, the issue becomes, I think it's 5 days a week for about 7 weeks. So it's pretty time intensive, complying with that. Now, the thing we worry about with these approaches, you keep in your parts, you keep in your prostate. Now, that can be a good and bad thing, meaning men will sometimes have their cancer controlled, but then have a lot of progressive problems emptying their bladder and urinating as a result of chronic changes from radiation. We also worry historically about secondary malignancies forming as far as leukemia or lymphoma. Less common with the techniques used today, but historically concerning. Brachytherapy is just a different version of that, except seeds or pellets. You may have heard people say I had seeds put in me. That's all the same thing. Now that actually requires an outpatient surgical procedure. You are put to sleep to have it done, but it's kind of a one and done phenomena, whereas the other approaches you gotta go for a couple of weeks. Same issues can arise though, as it relates to radiation within the prostate. Now the surgical options, though tried and true, was an open surgical cut where you were cut below the belly button, prostate and the lymph nodes were removed. Notoriously, that resulted in sometimes transient, if not lifelong, incontinence and erectile dysfunction. To work around some of these things and to minimize the risk of blood loss and just the recovery from this, a newer technique was employed using robotics, where it's small cuts that are made, and basically the goals are the same: get the prostate out, get the lymph nodes out, but minimize the risk of incontinence to where maybe it's just a couple of weeks or a couple of months and then you get your control back, and hopefully preserve erection. Now, in my experience, I do a fair amount of these. I always tell my guys, this is the hardest thing for me to predict. I have some guys that are young, that have full function, that bounce back really well, but oftentimes it does take a period of time with medications required, like Viagra, Cialis. So normally that department is never the same after a surgery, okay? It's gotten a lot better than what it was, but I always tell men that that's always the issue that we're still trying to refine. But once again, the advantage over the open surgery, it's less blood loss, there's less pain, you get out of the hospital quicker, and it's pretty much supplanting open surgery as the standard of care for prostate removal. So, just here's this picture again blown up. Once again, your prostate's here, so you got to appreciate your bladder's here. There's a channel called the urethra where that urine runs through. There's a sleeve of muscle right below the prostate that is a sphincter muscle that controls your urine. And there are two nerves that are not demonstrated here that come off your spine that come around to the left and right of the prostate and go out that control your erections. So any type of work that happens in and around the prostate can adversely affect peeing and also erectile function just by the sheer real estate, if you will, that's around the prostate, okay? Now, in a man who does have some chronic issues urinating, sometimes we kill two birds with one stone by taking the prostate out, getting him through a transient period of leakage, but then this prostate is no longer an issue moving forward in time. So, prostate cancer treatment. One of the things, the holy grail of what we try to do is trying to pick the people who are going to have aggressive prostate cancer versus people who are going to have the kind that take 10, 15 years to manifest. And most prostate cancer, speaking in generalizations, do just that. They're very slow growing. I joke with my patients, they're the tortoise of cancers. But once again, it would be nice to know if we had a specific test that can tell us who was going to behave in that fashion and who was going to behave in the more aggressive fashion that we would maybe want to offer more definitive treatment up front. So this test has come out. It's a genetic test that's performed on the biopsy specimens that are obtained. And basically it's a genetic test that's looking to determine just that, who has the bad form of cancer, if you will, and who has the more indolent, slow growing. The goal of this would be to try to select out men who would be candidates for just watching this thing and not doing anything and foregoing any problem that we talked about as far as erections and urination and whatnot, okay? Whereas we want to find out who's got the bad guys too and maybe be more aggressive with them. So basically tailoring treatment and minimizing side effects is what we're trying to do. Robotic surgery. So once again, I don't want you guys to feel like you're at the barbershop getting a haircut recommended to you, but I am a robotic surgeon by trade. I like doing it. I trained at a high volume center. And the bulk of my experience with surgery was using this thing, whether it be for prostate removal, partial kidney removal, female surgeries. It's a great piece of technology, and it's done a lot of my patients a great deal of good in recovery and getting rid of these problems. Now, interesting side note on this, just a little bit of anecdote here. This technology was created by the U.S. military. So these things were designed to be mounted to the back of a Bradley fighting vehicle and used in the field to help injured troops. Now, the fact of the matter is, it never really found that utility because it takes about an hour from the time the patient's asleep for me to wheel this thing in and get everything centered. It takes a lot of time, and it just, for the purpose of trauma and battlefield injury, it's just not practical as it stands right now. But with that taxpayer dollar, that's how this technology came to be used. You may also have seen in the news that, is robot surgery safe? What's going on? FDA is currently investigating kind of this spike in adverse events that have occurred with robotic surgery. Now, I'm familiar with the study that's come out. The amount of robotic surgery being performed throughout the country, you can see the numbers here, it's growing, okay? As practitioners get more comfortable doing it and more hospitals are getting robots, you're seeing that number rise. And you are seeing some adverse events that are occurring. Now, what I tell people, I use the technology weekly, and I'll tell you, I've never had a problem with the technology in and of itself causing a problem. The times I've had an issue have been with patients who predictably were going to have very hard anatomy, prior gunshot wounds, where it's not so much a complication from the technology, but it's just an anticipated complication that may have occurred if the patient was done using an open surgical technique. I think that what we're seeing, and what I postulate is, the issue is more of the people and the team that are in control of the technology, meaning there's a lot of good evidence to suggest that high-volume surgeons who do this a lot will have better results and less complications. That makes good sense to anybody who does anything. But what I think we are seeing is, I think smaller hospitals and maybe people who are not as comfortable taking this on are trying to, and I think you're getting less than desirable outcomes. So whenever I have a patient, I always tell them, you want to ask your surgeon, how many have they done? How comfortable is the hospital using it? Those are the things that I think are leading to these problems. And that falls back to the Malcolm Gladwell philosophy that it takes 10,000 hours of something to be good at it. So I think to some degree these people are potentially these locales just haven't had their 10,000 hours yet. So some final points that I want to make. Leaving this discussion, I want you guys to realize testosterone is your friend. It's not your enemy. Within our society, there's a big stigma regarding testosterone use. I think this is a pretty telling picture. I remember this as growing up. This was my first experience seeing or hearing about steroid use from Ben Johnson. But growing up, and we see the shame of McGuire. It's all throughout our society that it's very much frowned upon and just thought as kind of a taboo kind of subject. So historically, it has a black eye. There's a stigma associated with it. But I'd make the argument that when safely and properly administered, I can speak from experience from myself and also from the volume of data that's out there as far as patient safety, that it can be done properly. And once again, the mindset that I give with my patients is we're not taking a person who's normal and bringing them to super normal levels. We're taking the person who's coming into our offices with complaints that are real, and we're taking someone who's deficient and repleting them. We're trying to get you back to a level where you can function. So once again, everything is interrelated. We make the comparison of testosterone levels as it relates to obesity and a myriad of other medical issues that arise as far as high blood pressure, diabetes. And this is a pretty telling picture. These are once again from the American Cancer Society, but it's basically the trend in obesity throughout the country. Looking back to the early 90s, currently to now, you can see that the darker the color of red, the higher incidence of people that are overweight, and basically the whole country is red. Okay. And there's this guy. I put him landing in the South. No particular location in general that I was intending him to be in, but I'm sorry if I have any Alabama fans in here. So, so how does that relate to kidney stones? Well, I see it all the time. Diet and lifestyle are probably the two biggest predisposing factors to kidney stones that walk through my office. Historically, kidney stones used to be a disease of men, of excess and overweight men. As time has moved forward and women are now approaching obesity levels of men, interestingly enough, the incidence of kidney stones in women are now approaching men. So I think that's a pretty telling stat. And I'm always keen to pick these things out whenever I'm talking with the patient who's come in with kidney stones. And oftentimes that'll lead us to a discussion about testosterone, and it opens other doors that sometimes need to be explored. So So I'll kind of give you guys these little free recs while we're here on topic here. You know, leaving this discussion, you know, general recommendations for most kidney stone farmers. Living in South Louisiana where it's hot and humid, it tends to be relative fluid deficiency. It's hot outside, we're sweating. So you want to try to get about 2 liters of water in as much as you can. And like I said, more in the summer and spring when you're outside, maybe, you know, sweating and losing a lot to the environment. Now, a lot of people historically used to think, man, you know, calcium was the enemy, that, you know, my doctor took me off all my dairy products and, you know, whatnot. But I still make kidney stones, doc. Calcium is not the enemy. In fact, you can sometimes acquire 2 problems where your kidney stone risk has not changed, and now you're becoming osteoporotic and your bone mineral density is going to be crummy. So once again, calcium is not the enemy. Oxalate, which, and I'm speaking under the assumption that 60–70% of kidney stones are calcium oxalate inconsistency. Oxalate tends to be the bigger issue, derived from tea, nuts, chocolate, and a host of other foods. I've listed the more common ones that most of my patients report. Doesn't mean you can't have these, but oftentimes you can substitute these things to help reduce your risk. Adding citric acid is helpful, lemons and limes. Lemonade in the place of tea. I can't tell you how many people we've made this transition because they don't drink water and they say, I just drink tea all day. And we kind of figure it out, and sometimes switching them to lemonade, you get the added benefit of volume and citric acid, and your risk reduction of kidney stones goes down. The other issue as it relates to obesity is sodium intake. Sodium is found in preservatives, canned goods. So a simple solution would be switching from canned goods to frozen vegetables, things of that nature, frozen goods instead of preservatives. Limiting seasoning, good luck in South Louisiana. I have no one in my practice that wants to do that. Prostate cancer screening should be individualized, not abandoned. So unlike the preventative task force recommendation, which to the gentleman's point almost seems like a death panel recommendation, I don't think we should just get rid of it. I think we should go ahead and, you know, look at the person on a case-to-case basis. If they're healthy, they're young, they understand the risk of the lab work and what we want to do with it, then I don't see any downside to checking and knowing about it and letting the decision be within the patient's hand and the physician's hand. So once again, your risk-benefit ratio as it relates to prostate cancer, it's going to change at various points in your life. You know, when you're my age and you're 36, I'm not that worried about it. As I get older, you know, in my 50s and 60s, that may be a little bit more on the front burner for me. My grandfather had prostate cancer, so it will be something I think about. But when I get above a certain age, 70, 80, I'd like to think I'm going to live to be 120, and maybe the technology will change where I can. But at some point, you know, I'm going to back off and probably not get it checked, and, you know, knowing that, you know, my time on earth is less than 10 to 15 years ahead of me. So once again, this tends to be a very indolent, slow-growing process. We seem to have tests that will allow us to be able to detect who's going to have the slow-growing and who's going to have the more active kind. It's a very treatable cancer, excellent cancer cure rates, whether you go radiation or surgery. Both of them do a great job. What I tell my patients is, when we're talking about doing something, you're picking your poison as far as side effect profile and what we're willing to tolerate. Now, I know this seems a little strange, but football is king. This is a true study. So this is back from 1998. They looked at soccer fans, albeit European football, and they looked at basketball fans, and they basically did studies where during the game, they took saliva samples for testosterone assays, and they found that the fans of the winning teams had higher testosterone levels than the fans of the losing team. Now, who knows what to make of that? All I can say is continue supporting your teams here locally, and that may help you. Puts a lot of pressure on Coach Miles, though. So once again, I'll leave y'all with this. You know, this is, you know, the French cyclists and the Tour de France and all, you know, pretty much a dirty, if you will, profession. So, you know, she's saying it's shocking, you know, if you use testosterone. And his rebuttal is it's more shocking that the French even know what testosterone is. I can get away with that because, you know, I've got some French in me, so.